Okay, well, thank you very much, and thank you, everybody, to be here. It's my pleasure to share with you our experience for the new tools developed by the Toshiba company and implemented into the Applio 500 platform. These tools mainly oriented in our experience for interventional ultrasound experience. So basically what we see right now is a huge development of these minimally ablating tumors and interventional procedures due to better guiding with ultrasound, due to new developments in the minimally invasive therapy, and also improvements in needle guiding, including the visualization of the needle track and tip, because this is still the major issue, the combination with contrast enhanced ultrasound and fusion imaging. So first of all, I think it is key to understand that ultrasound-guided procedures has major advantage, including the true real-time imaging technique, the high spatial and contrast resolution, a very large availability, the non-toxic, it's mobile, and also it includes 3D and 4D capabilities with, together with contrast-enhanced ultrasound, and we can still use Doppler ultrasound for vessel identification. And just look at this, the biopsy of this lesion really sitting against the colon. You see it extremely well using the high-frequency convex probe, and then we can puncture it and get the diagnosis of renal cell carcinoma in a very, I would say, in a very risky situation. But of course, in some cases, the needle track is difficult to see. This is mainly in obese patient or with liver steatosis. And there's a loss in image quality after biopsy or radiofrequency ablation due to gas deposition. And again, there's a limited evaluation of surrounding sensitive structures like the bowel. And that's why ultrasound should not be the unique guiding technique. The CT advantages are well known. They include high spatial and contrast resolution, needle track visualization, limited operator dependency, and again, look at this tumor, very poorly located at the very anterior part of the kidney, and because of this guiding tool, we could really position exactly the tip of the RF ablation electrode right at the site of the tumor with a very oblique pathway and be successful in ablating the lesion. However, with the CT, and despite the presence of CT fluoroscopy, there's no real-time guiding imaging technique. There's the limitation of the administration of iodinated contrast media, and almost 30% of the patients now that we treat have moderate to severe chronic renal failure. Also, it's a time-consuming. There are some limitations due to metallic artifacts, a limited availability because the CT machine is a very busy imaging modality, the cost, and of course, the radiation exposure. The major idea is that we should dedicate the best systems for guiding and developing complex procedures, complex interventional procedures, and not what is done in the most of the centers is using the older or old systems. And first of all, I would like to show you a few examples of visualization of the needle track and the tip after selecting the appropriate transducer. Of course, there are some cleaning issues, and paying a special attention to the transducer position and the optimal, to optimize the path, the focal zone, and the prop tilting. But look here, this is just a puncture of a vein. This was the unique vein in that patient, and you see extremely well, you know, the position of the catheter, and also here you have the needle with the metallic needle in it, and here you have the catheter in place. So really a very high quality imaging is required for these procedures. Again, having the optimal set of transducers is required. I just want to show you the biopsy of the same lesion that we saw before. You see that using the conventional low-frequency transducer, convex transducer, the lesion is very difficult to assess, while using the high-frequency transducer, the lesion becomes really obvious, and then guiding the lesion inside guiding the needle inside the tumor becomes really obvious. And this is the follow-up of this patient with now more than 3 years follow-up, showing that the lesion remains perfectly treated, and that's a patient with a unique kidney. So again, good visualization is critical. Good visualization of the target, good visualization of the needle track, good visualization of the tip of the needle. This is, again, cases, all of these cases are from our real life. This is a renal transplant case with a massive diffuse collection surrounding the kidney, and the patient required renal biopsy. Of course, for this, you should not go through these liquid collection. And to find the exact path, look how well we can see the needle. We can see also the tip of this biopsy needle, and then we'll see extremely well when I will take, the sample here, and we see exactly where we got the sample because of this high imaging quality. We also very commonly use contrast enhanced ultrasound to improve the visibility of poorly detected lesions for tumor characterization, evaluation of the tumor shape and delineation, tumor perfusion, and tumor residue or recurrence. Let's see first one case of a lady that came with a quite typical angiomyolipoma, and just above you could see that there was isoechoic, or I would say slightly heterogeneous renal tumor that we could measure. The first idea would be, are there these two different angiomyolipoma with different shape, but with the injection of the contrast agent, you see very well these small cystic areas that are highly indicating the presence of a small renal cell carcinoma. And then the issue was obviously to do the biopsy of this lesion, and again, look at the good visualization of the track and localization exactly of the tip of the biopsy needle right at the level of the lesion that was obviously a small renal cell carcinoma. This is a case from last week. A lady coming 3 weeks after committing suicide with very complex pelvic fractures, recovering from acute renal failure with a fever and abdominal pain, and she was referred for ultrasound in our group. So that's the shape of the left kidney, and of course you can probably notice that the kidney has not a normal shape. Was this a hematoma? We don't know very well. And so despite this heterogeneity, the perfusion or the color evaluation of the flow was not so bad, despite the fact of some heterogeneous areas. And after injecting contrast agent, here in this case, the sonoview, we can see extremely well that these are abscesses, and in fact, she has acute pyelonephritis with abscesses, multiple abscesses. And the question then was, how could we perform the drainage of this lady? We could perform despite the presence of the mild renal failure. We did once a very small amount of iodinated contrast media just to get confirmation of the diagnosis, and you see the correlation of these abscesses to the contrast-enhanced image. But I would like you to pay attention now to the loop with the needle arriving in. Okay, so apparently this is not working anymore. Okay, so this should be a loop where we should be able to see the needle arriving, and I don't know why this is not running, because it was before. I'm sorry about that. Okay, let's go on. Another case where there was a difficult case of a lady that got surgery and partial tumorectomy or tumorectomy for this tumor. And then during the follow-up, since the beginning, a small heterogeneous area was detected at the level of these primary resected lesion that was 2 years ago. And this lesion remained stable, and with the color Doppler we had no additional. This was considered to be a small hematoma at the site of the tumorectomy at the site of the previously seated tumor. And then we performed the contrast-enhanced examination, but look, here we have a very obvious enhancement of the lesion, and you see that this lesion is absolutely not a hematoma because it's picking contrast, and you could delineate pretty well the tumor. But note also the presence of enhancement in the surrounding tissue here against to this kidney. And we suspected the presence of a path seeding, tumor tract seeding. And this is the MFI with the accumulation of the microbubble, and we could see very well this tumor. And basically, it's a recurrence after tumorectomy, so after surgery. So tumor can recur not only after ablation, percutaneous ablation, but also after surgery. And this was the imaging CT and MRI, and you could confirm that there was some enhancement that were not previously reported. And of course, we had to biopsy this lesion, and again, you take benefit of the very good visualization of the entire needle and also of the lesion itself, and we could biopsy directly, and this was proven needle tract seeding during the previous surgery. So again, in some cases after RF ablation, the identification of a residue, tumor residue is difficult, and this is during the follow-up. This is the 1-year follow-up after ablation of this lesion, and the color Doppler is not showing anything wrong. With the B mode, you see some very heterogeneous pattern of the lesion. But when we inject the contrast, look at the nodular pattern developed here, enhancing, very strongly enhancing, just demonstrating the presence of a small nodule enhancing within the site of the tumor, which is very typical for persisting tumor in this case. What we commonly do is we adaptate the ablation protocols to the tumor perfusion. So for all tumor ablated in our center, we calculated tumor perfusion indices to get a better idea of how much blood is flowing in the lesion and to optimize the ablation procedure. So in these are the few cases we're using that software. We could really see these, all of these are 3 different renal cell carcinoma, and you see how much variable can be the perfusion index. Going to the next step is clearly taking advantage of both CT and ultrasound performance for ablation, and this is clearly the fusion imaging techniques. Of course, this is not completely new in the field of ultrasound, but now it's becoming available with into the Aplio 500 series. Basically, the fusion imaging with ultrasound is a challenge because of the variable position between the previously referenced CT or MRI, the current CT, and the ultrasound imaging. Also, there are some issues dealing with the superimposition of variable plans, and this should be available combined with all ultrasound technique, conventional B mode, but CUS, and also 3D. In some cases, the patient will move in between during the procedure, and so the registration should be fast and accurate, and that's why we need the system to be able to redo the procedures very quickly. In this setting, we evaluated the Aplio 500 together with the magnetic sensor technique, and there was a magnetic generator here, and the magnetic sensor is located right at the level of the ultrasound probe, and this is the real setting during the ablation procedure. This is a patient with a difficult lesion because this kidney had previous surgery, and this is the unique kidney in this patient, and has two big tumors. One is here, and the other one is located more anteriorly. So basically, the CT and MR DICOM data were loaded into the Applio system to allow simultaneous dynamic display of CT and of course, ultrasound, automatic tracking of the transducer sensor together with a rapid and simple registration. I don't want to go too much into detail about the procedure itself, but it's really a rapid procedure where we fix one transverse plane and then we locate one target point, and then basically we can achieve quick fusion. So let's see the case from the real life, because that's what we are dealing with. This is the patient with a bilateral multiple renal cell carcinoma. This is a patient with a von Hippel-Lindau disease, and she had previous surgery on both kidneys, and she's now under sunitinib treatment for these lesions, and unfortunately with very poor tolerance. So these are the lesions. One is here, quite big, almost 4.5 cm, and the other one is more anterior. So let's see the loop from the real life. So we could really detect and correlate the two planes, and you can see how good is the correlation between. We can also do this with contrast-enhanced ultrasound, and you see here that the lesion is slightly cystic. So we could locate exactly, very precisely, the RF electrode at the level of this lesion, the first one to be treated, and we could evaluate the results almost immediately after the ablation, looking at the ablated area and being sure that this area is covering the place of the previously detected lesion. And this is the CT that was done the day after, because we did not process immediately for CT the patient. For the largest lesion, then the situation is much more difficult, of course, and with such a big lesion, we could better evaluate the position of the lesion. You can notice the necrotic parts due to the sunitinib treatment, and we could also put the two electrodes, you see the complex path, and look at the ablated area compared to the CT and the previously ultrasound performed. This is the ultrasound performed after the ablation, and you see how well the ultrasound correlates with the CT features. Let's finish with another case. This is a liver case in a 75-year-old man with chronic C. hepatitis and renal transplantation, and you see that the lesion is not so well delineated on MRI because the patient is quite old and breathing continuously. So with ultrasound, we could see it, but despite the high quality of this ultrasound scan, this is done intercostally, the limits of the lesion are not so well defined. And that's why contrast-enhanced ultrasound is really useful, because you can not only characterize the lesion, but much better appreciate the real size. And then also we can have the delayed phase, and you see the washout that occur very, very soon, almost 40 to 50 seconds after the injection. You can assess the washout phase. So basically, we've used the data between the CT, and you see that how CT is not showing very precisely the lesion, the location of the lesion. And we then put the three different electrodes to ablate the lesion, and you could evaluate the immediate result. And you see this very large, non-perfused area with probably some enhancement, some peripheral enhancement. But we know that this is not necessarily the sign of the presence of a tumor residue, but mostly the reaction of the tissue. So clearly, the new tools for interventional ultrasound application are playing a growing role to improve the lesion detection and characterization. That's a key step, of course. If you don't see it, then it's becoming much more difficult to improve the needle and electrode visualization, to improve the needle and electrode placement, and that's the key point of adding the fusion benefit. So clearly there's a better diagnosis and treatment planning. The advantage for us as using the fusion imaging is the detection of the small isoechoic or even non-visible lesion at ultrasound for treatment planning, defining new routes, and this is a key step, for reducing the duration of the procedure, and now our waiting list is up to the end of June. It's completely full. So really, we want to be able to do more patients for each session, optimize human resources, reduce radiation exposure, and better follow-up. So, of course, this technique needs some training, and of course, they also have a cost, but you could see the major impact on the patient workflow. Thank you very much for your attention.